Okay. Hello and welcome everyone to today's webinar for mental health professionals, Suicide and Suicide Prevention, Ethical and Legal Perspectives. Please note that this webinar is being recorded and will be available as an on-demand webinar within 24 hours. Thank you everyone for joining us today. My name is Sasha Sicard and I am the Education and Membership Manager here at ADAA. Before we get started, I would just like to go over a few items so you know how to participate in today's webinar. You have joined the webinar as a participant today, and as such, it will be muted for the duration of this presentation. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer. You will have the opportunity to submit text questions through the Q&A feature seen down at the bottom in your attendee interface, and you may send in your questions at any time. We will collect these and address them during the Q&A session at the end of the presentation. For those who purchase CE or CME credit for this webinar, you will receive an email with a link shortly after the completion of this webinar. This link will include the webinar survey and post-test questions required to receive the certificate. Please reach out to webinars@ADAA if you do not receive this link within 24 hours. I would like to now introduce our wonderful presenter. Thank you for joining us, Dr. Jacob Appel. He is currently an associate professor of psychiatry and medical education at Mount Sinai School of Medicine, where he is director of ethics and psychiatry. He is the author of 4 literary novels, including Millard Salter's Last Day, 10 short story collections, and an essay collection, a cozy mystery, a thriller, and a volume of poems, as well as a compendium of medical dilemmas. Wow, way to go, Dr. Appel. He is a co-chair for the Group of Advancement of Psychiatry's Committee on Psychiatry and the Law and a judge for the National Book Critics Circle Awards. Thank you for joining us today. There will be a brief transition while I give the presentation role over to him. Go ahead, Dr. Appel, whenever you're ready.
Okay. Thank you for that introduction. Can you see my screen?
We can indeed.
Let me make it bigger. Now you can definitely see my screen.
There you go.
I really appreciate the introduction. I always remind people, to my mother, I'm still her son who's not the rabbi. But that's actually a step forward. I used to be her son who's the psychiatrist pause. He's almost a real doctor. So I'm making progress. That being said, I'm going to talk to you today a bit about suicide and suicide prevention from ethical and legal perspectives. I am not a suicidologist. I am a bioethicist with a law background. I also work in a psychiatric emergency room. So take what I say with many grains of salt. I will probably speak for about 45 minutes. It has now been about 25 years since I gave my first talk on suicide ethics. And I remember the late Edward Beiser, who was the faculty member who invited me to give the talk at Brown, when he found out I planned to speak for 90 minutes straight, said that if I spoke for 90 minutes on suicide, he would end with a demonstration. So with that in mind, I will try to keep it a little bit short and we will take some questions at the end. I always like to mention that by arrangement with the medical school at Mount Sinai, does not allow me to see private patients. So please don't send me referrals as much as I would love to be of help. 3 things I want to talk about today. I want to talk about rational suicide, and particularly rational suicide as it relates to mental illness. I want to talk about end-of-life issues and substituted judgment related to suicide, and particularly involuntarily hospitalizing patients who are both suicidal and terminally ill or in other ways in jeopardy. And then finally, and probably the most controversial thing I want to talk about suicide liability, and particularly make the case that how we approach suicide, both in the ED and the inpatient setting, in ways that are designed to lower suicide rates and suicide risk, may actually in the long run not have that effect and may even increase it, largely because we're afraid of liability. So, and that's very controversial. You're welcome to disagree, but at least I will throw that out there. I want to begin with a joke. And I mention that partly because I want to emphasize the rest of his talk will be fairly serious and a very serious topic, but also because if I didn't tell you it was a joke, I'm a bioethicist, not a comedian. You might not realize that. So with that in mind, 2 psychiatrists are in a bar one night watching television, and they see a person on a ledge about to jump. And the first psychiatrist says, I'll make you a bet. I'll make you a bet she doesn't jump. And the second psychiatrist says, I'll take that bet. I'll put down $10 she does jump. and they watch, and unfortunately the person on the ledge jumps, and the second psychiatrist goes to collect his money, and the first psychiatrist says, I want you to know, I feel badly, I was unfair, I actually already watched this on the 6 o'clock news, I knew it was going to happen. And the second psychiatrist says, well, if you know what was going to happen, why did you bet she wasn't going to jump? And the first psychiatrist says, well, I didn't think she'd do it again. You understand the pedagogical point of that joke. We know what causes suicide, or we think we do. We see the same patterns of behavior, and yet it's also unpredictable in its own way, to the point where we second guess ourselves on thinking what's going to happen next. And I want to talk a bit about my own novel, Millard Salter's Last Day, because I think there's something pedagogical in it. So a number of years ago, candidly, after the department at Mount Sinai told me to stop talking about rationalist suicide, I thought rather than talk about it, I would write a novel about it. So I wrote this novel, Millard Salter's Last Day. And Millard Salter is an elderly psychiatrist, or an elderly relative. He's in his mid-70s. And after his wife passes away, he decides to volunteer helping other people who are terminally ill end their own lives through an illicit assisted suicide program, sort of like what used to be the Hemlock Society underground. And he volunteers. And unfortunately, the first woman he's assigned to escort out of the world, he falls in love with. So in response to this, he decides that when he turns 75, after he helps her end her life, he can end his own life. I won't tell you how the novel ends. What I will tell you is the novel was designed entirely to be a rationalist suicide novel. So I carefully went through the novel as as a psychiatrist with expertise in the field, making sure all the factors that we'd normally be concerned with in suicide, depression, anxiety, helplessness, pain, disease, mental illness of all sorts, were all removed, so that it would seem like someone who had for many years thought about exactly what he wanted and then would do that. In spite of that, I would say I got over 1,000 messages, either email or letters, from various people, many of the mental health professionals, explaining to me why Millard Salter was actually mentally ill and shouldn't go through with what he planned on doing, which amazed me because it says that we view things through a very specific lens and we shape the facts accordingly. So a bit about rational suicide. There are many contexts in which rational suicide historically has been viewed as noble. So the example that most obviously comes to mind is during military service. There were forlorn hope squads. The concept first became known during the English Civil War, though it's also associated with the French term enfant perdu from the Napoleonic Wars. Soldiers who basically were sent into battle with their own consent, knowing that their likelihood of survival was virtually zero. Very different from people going into battle knowing they have a high risk of dying, but hoping they might survive. These were soldiers who knew they were going to die, and it was considered a very noble death, and history looked favorably upon them. That is Phich Quang Duc, one of the first Buddhist monks to set himself on fire to protest American involvement during the Vietnam War. Again, a heroic figure in Vietnam. And finally, that is Linda Fleming. She was a woman with pancreatic cancer. She was the first woman to end her own life under Washington State's Death with Dignity Act, which was the second U.S. state to legalize aid in dying. And I ask you, are these part of a continuum, or are they distinct phenomena? And then there is suicide-homicide, and I only use one specific example. You may be familiar with the siege of Masada in the early first millennium. The Romans had besieged a fortress of the Sicarii, a radical and zealous Jewish sect. And at least according to the historian Josephus, the inhabitants, rather than fall to the Romans, murdered those who were weakest and then killed themselves in this mass murder-suicide. What's interesting today, and some of you may have visited Masada, is the current scholarship strongly suggests that there is no evidence of suicide at Masada. Whether suicide at Masada actually occurred versus a massacre by the Romans, we will never know for sure. What is interesting is that when historians or archaeologists or people bring forward evidence suggesting it was not a suicidal event, there is a backlash from those who were invested in defending it as such, which raises the suggestion that in some contexts, we actually do view suicide as noble and the legacy of suicide as one worth protecting. This gives you a sense of where assisted suicide is legal in the United States right now. It started in Oregon with the Death with Dignity Act in 1997. Unlike in parts of Europe, there are very strict parameters in most states. Patients need to be terminally ill. They have a limited time frame. They have to make multiple requests. The 2 points I want to make are one, whether or not one thinks assisted suicide should be legal in the United States or not. The people who benefit from it, both in my own clinical experience and from the data, are not the people who actually use it. There may be a small number of people who end their own lives this way who benefit, but a far larger pool of people benefit knowing that it's legal, even though deep down they know they're ever going to use it. And I have had patients in various contexts say to me, and consulted in cases where someone says, I'm really not going to do that, but knowing that I could do that as a last resort gives me hope to go on living the way I am now. So worth thinking about. The other thing worth thinking about, you'll notice the state of Montana. Montana is the light pink, the light blue state. All the other states where assisted suicide is legal are in dark blue. In Montana, assisted suicide or aid in dying, and depends which side of this issue you can use the term, was legalized by the courts. However, my understanding is it is still not occurring, in part because the Montana Medical Association has refused to endorse it or accept it. And the result is that no physician in the state is willing to embrace the practice. An aside, by the way, that just comes to mind, you may remember or may have read about the Eichmann trial written by Hannah Arendt in Israel. He was a Nazi war criminal. He was tried by the Israelis. They told him he could have any member of the Israeli bar defend him, but it was a meaningless right because no member of the Israeli bar would step forward to do it. Analogy is it doesn't really do you very much good if we tell you have a right to aid in dying if no physician in your state will allow you to do it. So if you are opposed to aid in dying, you might take a position that the AMA or the APA or the American College of Physicians should expel members who engage in the process, which they currently don't, even though they don't endorse the process. Very different from, let's say, their approach to capital punishment or torture, where they will throw you out if you violate the rules. I'm not endorsing that view. I'm just saying that we have a continuum, and depending on your view on this issue, you might have a different standard for how hard we should push to force people in our profession to conform with it. And that gives you a sense of assisted suicide in the world. Again, this is for physical illness. Most, but not all of these countries restrict to people who are terminally or debilitatingly physically ill. And then there are the countries which permit rational suicide for the mentally ill. And Switzerland was the first of these. It has since been decriminalized in Belgium and the Netherlands. Some of you may be familiar with the rather unsettling expose that Rachel Aviv wrote in the New Yorker a couple of years ago about assisted suicide and aid in dying in Belgium. And it seems like the safeguards that are being used in the US and have been proposed for even those with mental illness elsewhere are at least very loose, which led to a lot of controversy. There is also Philip Nishke. He's actually built a machine that can be made with a 3D printer to hasten death for people who choose it. There was a concern that this would lead to contagion among mentally ill. The Australian government both prevented it from speaking and tried to suppress the development of this device. There is rapid expansion of the use of assisted suicide for the mentally ill in countries where it is permitted. So in 2010, there were 2 cases in the Netherlands. By 2015, there were 57. That number has continued to climb. I actually have the data for the kinds of illnesses that people chose to end their lives with in the Netherlands in the first 5 years it was available. And you can see there are disorders that, from our point of view, should be treated, or I assume most of our points of view, where suicidality is viewed as a symptom of the illness, like depression, anxiety, psychotic disorder, prolonged grief, and get a sense of some of the other ones slightly below. So there are 2 sets of patients you might think about beyond the traditional mentally ill patient I will talk about in a second. And you want to ask yourself, to what degree does diminished capacity prevent you from having the choice to end your own life in the context of mental illness if you embrace it for physical illness? So the first are the patients who do not meet the most basic elements of capacity, psychosis, people who are psychotic, people who are intoxicated, with regard to suicide. And most of us, I would assume, would agree that if you don't meet a basic capacity assessment, you should not be able to make this choice. But then there are people who meet some or most of the elements of capacity, but are thought to lack full capacity due to the influence of mental illness. So they're depressed, but they also may have a rational desire to end their own lives. Or they have borderline personality, but they also may have compelling reasons. And those are of 2 different sorts. One, they may face stresses that even a person without their illness in their situation might, they not necessarily would, but might choose to end their lives over. For example, they might also have a terminal illness, or an additional social stressor that would lead us to want to end our own lives. So that is one possibility. Or, and I'll talk about this more in a little while, they may come forward and say, I tried. Medicine has all of these interventions to offer, and I really gave them a fair shot. I tried antidepressants, I tried ECT, I tried inpatient admissions, I tried supportive care and therapy, et cetera, and nothing seemed to work. And now I'm in my 70s and I'm still really depressed. Does the diminished capacity of their illness outweigh their rational desire? That is a question we as a field are going to have to confront as this expands. And then finally, there's the comparison to general medicine. So I want you to think about the two cases. So unlike general medicine, there's a patient who says, and we'll pretend this is confirmed, I've been depressed all my life, tried every treatment, nothing has helped. Please let me in my own life in a safe, painless way. The case I just mentioned. But then there's a second case that might arise, which is very similar to general medicine, where the patient says, I've had bouts of depression and mania my whole life, but not right now. Right now, I feel fine. I don't want to go through that again. Please let me end my own life in a safe, painless way. And does context matter? Obviously, if you say this and you're a 19-year-old who recently broke up with their prom date, we're going to view that, I think, very differently from someone who is 70 years old, who says, I have a whole perspective on life to look at behind me. But we also want to avoid the risk of devaluing or not appreciating these social stressors of being elderly. So there's a hard needle to thread if we're ever going to permit this. And then related to this is the question of suicide-friendly psychiatric advance directives. So I imagine most people on this call understand psychiatric advance directives, which are similar to medical advance directives, only they are not binding in most states. The Nancy Hargrave case is probably the most famous of them from Vermont, but I will offer you a hypothetical to give you a sense of how they play out one way versus another way. So playing off the Nancy Hargrave case, let us say one is a state patient in a state hospital and one has schizophrenia and one is stabilized, and one says, being on medication is a miserable experience for me. It doesn't make me feel like who I am. However, I'm willing to live in a state hospital indefinitely if I have to avoid being on medication. So when I'm stabilized, I get a forensic psychiatrist to evaluate me to establish that I have capacity to make decisions. I get a lawyer to draft up a psychiatric advance directive binding me to future situations, saying I don't want to get care. For those of you who have read the Odyssey, we often think of these as Ulysses contracts. After Ulysses, who to hear the sirens, bound himself to the mast and told the sailors to put wax in their ears, and he listened to the beautiful music of the sirens. No matter what he told them, they were instructed not to listen to him while he was listening, and not to untie him. He bound himself for a future situation. So in the same situation here, you bound yourself to a future situation, you get the whole thing videotaped, so there's no doubt about evidence, and then you relapse again. So Vermont and several other states now have accepted the principle that under those circumstances, you can commit yourself to being held long-term in a hospital rather than taking medication. It actually turns out, for those of you who are worried about the taxpayers, it's probably more cost-effective to keep you in the hospital indefinitely under those circumstances than to arrange appropriate outpatient services with the likelihood that you're going to relapse over and over again. However, if you create the exact same document, but rather than saying you want to live without antipsychotics, you say that if you become suicidal, you want to let nature take its course. We don't honor that. Even if you have a forensic specialist evaluate you for capacity, a lawyer draft an agreement, you have the whole thing videotaped, your family's on board, we view it very differently. And my challenge for you is to think about why we view it very differently. That leads us into a second set of cases worth thinking about, which are cases related to the end of life and substituted judgment. I always like this cartoon, you never think it's going to happen to you. So the two key questions relate to the involuntary commitment of people with terminal illness, or for our purposes, other severe or debilitating phenomena. And the two questions to ask are, should the assessment of patients with advanced or terminal illness differ from other patients when evaluating them for involuntary commitment? Meaning, should we have a higher threshold to lock someone up at the end of life than we do under ordinary circumstances? And two, should the assessment of patients with advanced or terminal disease differ from other patients when evaluating for discharge from involuntary hospitalization? Meaning, once you're in the psychiatric facility, should we have either a higher or a lower bar for letting you go? So a couple of cases we're thinking about. to give you a sense of my thinking on this. So Fred is a 72-year-old retired physician who was diagnosed with metastatic adenocarcinoma of the pancreas as an incidental finding during hospitalization for pneumonia. You can all picture this case. Well, prior to being informed of his cancer diagnosis, he'd be bright and cheerful when interacting with the medical team. Now he appears so dysphoric that a psychiatric consult is called. He refuses to engage with a psychiatry consult beyond saying, does it matter if I go home and shoot myself or if I go home and I die of cancer? I know the numbers. I have 3.5 months to live without chemo, maybe 8 months with chemo. Who wouldn't be suicidal in my situation? But if you want me to say that I'm not, so you can have a clean conscience, you can write down in the chart that I'm not suicidal. Now, obviously, we can talk about latent thoughts and what Fred is really trying to tell us, but taking him at face value, he seems to be at reasonably high risk. Fred refuses to engage with a psychiatric consultant on the next 3 encounters, pulling a blanket over his head and stating, I've said all I have to say to the head shrinkers. You should ask yourself, should Fred be hospitalized under these circumstances? Is this the same as an ordinary psychiatric patient, or is it somehow fundamentally different? So one of the challenges is protecting vulnerable populations. Patients with mental illness have higher mortality rates and less access to cancer care and other similar care than other patients. One does not want to exacerbate this inequity or shortchange these patients by undervaluing their lives. On the other hand, while we clearly have legal grounds to hold this patient to prevent him from harming himself or presumably others, the ethical justification is harder. The ethical justification for involuntary commitment, as we know, is to restrict a patient's autonomy temporarily with the goal of treating and rehabilitating the patient so the restrictions upon their autonomy are no longer possible. But in a situation like this, you have to weigh this against the very narrow and constricting time frame of how long the patient is going to live. Psychiatric units, and I will show you some data on this in a bit, are rather restrictive. They're not terribly pleasant places. I say as someone who's worked on one, they're designed for treatment, not comfort. How do you balance this against the need to preserve Fred's life, against the existential suffering he will experience on a locked unit during the final days of his life? I compare this, by the way, to a heated ethical debate that occurred between palliative care and psychiatry in many major American hospitals, including my own, between the 70s and 90s. You have patients who would wake up with a C3, C4 spinal fracture, and obviously they were never going to breathe again. They would be having an adjustment reaction, become terribly depressed. They would say, turn off my ventilator. Palliative care would say, patient is suffering existentially, please end this for them, turn off the machine. Psychiatry would say, give us at least a year. Data shows that a good portion of patients after a year feel better about themselves. We'll show them pictures of what they can do. We'll bring in Christopher Reeve. And this debate went on for many years. Largely now has been settled in favor of palliative care. So now to revisit our case. You have admitted Fred to a psychiatric unit and he refuses to meaningfully engage in evaluation. On the unit, he isolates himself, appears highly dysphoric, refuses to accept quartered antidepressants. So you can ask yourself how far along this you escalate this. Would you go to court for involuntary ECT? If you failed ECT, would you transfer the patient to a state hospital? Is there a tipping point where ethically, ignoring the liability, you simply say Fred is at the end of life and letting him make his own choices makes sense? I also want to mention, I already mentioned the issue of the ticking clock and the latent desire to stay in the hospital. You want to know what the end game is when you start down this path. So you want to think, at what point am I going to let Fred make his own decisions when you first admit him to a hospital, rather than finding yourself chasing your tail, escalating care further and further simply because you escalated care earlier. A few more facts about Fred, just to put this in context, and this is hypothetical. He has a history of significant alcohol use, for which he does not want treatment. He lives with his wife, Wilma, of 60 years, and has no children. He stated to the doctor during the course of his 6 weeks on the unit, Wilma can't possibly navigate the world without me. I hate to see her try. Honestly, she'd be better off going when I go. Now, this should be a different set of red flags for you. If you want to read more about this, there's a wonderful book to which I contributed by Susan Hatters Friedman on family murder, and the part I have contributed to is on murder-suicides in the elderly. Data suggests that family murders, and particularly spousal homicides among the elderly, increase significantly after serious or terminal medical illnesses. So maybe this is a different set of considerations where suicide risk bleeds into homicide risk. But we have to ask ourselves, at what point do we let patients' family members substitute judgment for the individual patients? So think about the following example. A patient with severe, potentially terminal illness wishes to end his own life via suicide. The physicians believe that his capacity is diminished, and we can say severely so as a result of depression. In discussions with the family, one of whom is also the proxy, the family uniformly emphasizes that while the patient may be depressed, even if the patient had not been depressed, he would have wanted to end his own life under these circumstances, and certainly would not have accepted anything beyond comfort care. Now, if the issue were dementia or an inability to communicate or any other constricting factor, we would defer to the proxy. So why rationally or ethically don't we defer to the proxy when the constricting factor is psychiatric illness? Um, how does this, or what rationale is there for distinguishing this case from the other medical cases? And I'm positing by raising that, maybe there is. Maybe we do this because we are in our silo and we view things in a certain way, but they're actually very similar cases. And now in my last 20 minutes, I want to shift to liability and prevention for suicide. And I want to emphasize very strongly, this is not a pro-suicide talk. I have people hear this and misinterpret that. My goal, just as much as your goal, is to reduce suicide rates. I just come at it from a different angle because I think what we've been doing now may not be working as effectively as we'd like. And what I'm basically arguing is that some of our suicide prevention techniques do not actually help those suffer from mental illness. So give you background, I know a lot of you may be suicide experts and know more about me, but there's a lot of talk in the media about the suicide pandemic. So the suicide rate in the US, for example, jumped 30% from 2000 to 2016, especially large among teenagers, but it's gone up really among almost every age group except for elderly men. And now it's either the second or the third leading cause for all Americans ages 10 to 34. I candidly don't know where COVID fits in on this list. And you see charts like this that show increased rates of suicide for women in both rural and urban areas, increased in 49 states between 1999 and 2016, increased by race, increased by method. I always emphasize if there are any trainees or younger people on this talk that the most common methods of suicide completion are firearm, suffocation, poisoning, and in New York City, I will add jumps or falls. I mention that because if somebody comes into your ER who is neither intoxicated nor psychotic with thoughts of killing themselves in a method that is not one of those four methods, you really want to look at the case very differently. In my experience in the ER, no one ever kills themselves by bringing their toaster into the bathtub or setting themselves on fire. It's an extraordinarily rare phenomenon. So really, these are the four things you want to look at. And the other clinical pearl, if there are trainees, and I work in a psychiatric emergency room both during the day and night, there's Perlis's work suggesting that people who come into the ER in the middle of the night who can't sleep are at much higher risk of suicide than people presenting early in the morning. Really, nobody kills themselves after breakfast. Why that is, we can discuss, but it's really a late night phenomenon is what you want to be on the lookout for. Particularly, you don't want to throw those people out of your emergency room at 3 in the morning. But now I want to step back, now that we've talked a little bit about public perception, to ask, is there really a suicide pandemic? Because you can look at the numbers dating back to 1950, and we're not in a very different place than we were in 1950. You can look at suicide rates 1981 to 2011. Again, we're in the same ballpark. Teenage suicide rates, even between 1975 and the present, have not increased significantly for men. There is some increase for females. Suicide rates per gender, again, where if you look at the long-term data, 70 years, and I realize there may be some confounding factors and reporting variables, don't show the pandemic that people speak of more recently. Though in all fairness, there probably is some perception of that in part because numbers for the rest of the world are going down. I don't say that to say that we shouldn't take suicide seriously. I say it because the concept of a pandemic, particularly in the current environment, may be scaring us and may be getting us to do things that we wouldn't otherwise do. You all know that suicide is probably a two-hit hypothesis where you have some kind of genetic diathesis and there's an environmental response. The argument that it runs in families like Ernest Hemingway's and Kurt Cobain's, and the very controversial thesis, which I am not endorsing, but I feel obliged to mention, that there may be certain ethnic biological groups in which suicide runs higher, like the Udmurt and Maori people of the Soviet Union. What I do want to mention and emphasize is there's clearly a difference genetically between the people who complete and the people who attempt. So multiple studies show that increased suicidal behavior and completed suicides were higher in relatives of individuals who committed suicide, but suicidal thought and ideation, once mental illness was controlled for, were not. In fact, suicidal thoughts ideation generally correlated with mental illness rather than clustering in relatives of suicide victims. So what is the point of all that? The point of all that is just because somebody shows up in your hospital, your ER, in your clinic, and says they're thinking of harming themselves doesn't necessarily mean they're going to harm themselves. If they don't have other risk factors, it may be a normal, if not healthy, way of expressing themselves. And you want to make sure you don't do anything to them so that later, when they are at risk of suicide or in need of mental health care, they don't get it. Um, so this gives you another data. Thanks to Valerie Porra-Cara. We know that according to her study she did, which was informal online, 43% of patients who presented to the ER said they did not have an intention to injure themselves, compared to only 36% that did, brought in for self-injury, actually wanted to kill themselves rather than just harm themselves. So in other words, only a subset of those with mental illness are at high risk for suicide, and it appears to cluster in families, genetic groups. And that may explain why certain medications, which reduce depression, don't necessarily, the SSRIs, don't necessarily reduce suicide rates. There's data from England and Sussex that some Amish fellows with bipolar disorder, suicide runs frequently, and others with bipolar disorder, suicide does not occur or occurs with extreme rareness. So needless to say, the leading risk factors in the ER for suicide are high lethality attempts, family history. Repeated low lethality attempts do not reduce your risk to baseline, but they may call for a very significant different management approach. Here you just see some of the different reasons people might present for suicide. What I want to emphasize is environmental factors. We talked about that two-hit hypothesis. Environmental factors play a large role, and they're often underplayed. So 64% of suicide victims have never been diagnosed with a psychiatric illness. CDC reports that 80% of suicides had a mind-altering substance in their system at the time of their suicide. Only a third of Americans in 2006 described themselves as happy, according to a Harris poll. The number's probably lower now as a result of COVID. The APA, American Psychological Association, 2011 reported that 44% of Americans were under increased stress and 49% had concerns about employment stability. And yet psychiatry has almost entirely focused on treating the patient rather than on treating the context of the patient. And I will not go into depth into the other field I study, but I do think we need to pay more attention as providers into the context in which people are living, because it gives us a sense of why they may be depressed. And rather than particularly treating their depression, we may spend more energy working on fixing their context, which admittedly is a higher lift, but maybe a higher reward. I urge you all to read Robert Putnam's book, The Collapse of Social Capital, called Bowling Alone. Putnam draws on evidence, including nearly 500,000 interviews over the last quarter century, to show that we, as Americans, sign fewer petitions, belong to fewer organizations, know our neighbors less, meet with friends less frequently, socialize with our families less often. We're even bowling alone. And it goes on, more Americans are bowling alone than ever. They're not joining bowling leagues. I don't think we can separate this from the perceived suicide pandemic. I won't go into great depth on the data on loneliness. I will say that a 2009 study showed that 30% of American college students expressed feeling so depressed that it was difficult to function, and 6% contemplated suicide annually. And that probably is a pandemic that grows worse with each year. So you may remember that a few years ago, Theresa May was mocked to be British Prime Minister in the media for appointing a Minister of Loneliness. This was after the late Joe Cox's commission found that 9 million Britons who are significant are always lonely. The data in the United States is about 46 million Americans. That should really give us pause. Here's some more data on loneliness. I will make these slides available. So here's my radical thesis. My radical thesis is that our fear of suicide liability is harming patients. And secondly, that our fear of suicide and suicide liability actually might be killing patients. I can talk about how it's harming patients very easily. So we had a talk from a senior administrator at my hospital online recently. And the punchline of the talk, I will never forget the quote, is that the most important goal of psychiatry is to prevent harm to self and others. The exact language may be different. That was the point. That is not why I became a psychiatrist. I'm hopeful that's not why all of you became psychiatrists. We became psychiatrists to help people, to make them feel better, to improve their lives, to treat their mental illness. One effect of that may be ending suicide or preventing suicide and preventing harm to others. But if that is your driving force, it lets everything else fall by the wayside. And you may have an over-inclusive approach that at an extreme level prevents self-harm or harm to others, but as a result causes an enormous amount of existential suffering, leaves a large number of people untreated in the most basic way, et cetera, or scares people out of the healthcare system. And that's the second point I want to make, and I'll talk about it more in a minute, that if people feel they're going to be hospitalized when they don't need to be hospitalized, then when they do need to be hospitalized, having had negative experiences with the psychiatric system or the mental health system, they may be unwilling to come forward and get the care they need. So I always like to ask people what all of the figures in this photo have in common. You can all think about it for a second. I will identify for them while you think. So on the upper right, that's Helen of Troy, the world's most beautiful woman. Going counterclockwise, that's Roger Bannister, the world's fastest man, maybe the most intelligent human being in Albert Einstein. In the middle, Napoleon, the world's greatest warrior. That is Lassie, the most loyal dog. At Grand Rounds every year, occasionally I get to humiliate people. I ask them if they know who all of the figures are here. I won't do that to you. Someone always raises their hand and they get through the first five and they get to the bottom left-hand corner and they get stuck because those were my late grandparents who were the world's greatest grandparents, but the odds of you having known them are very low. What do they all have in common? They're all dead. Let that sink in for a second. My point being that the mortality rate is 100%. So preventing mortality can't be our only goal. Suicide, at least with our current tools, is the natural course of many illnesses. You may be able to prevent it in a specific person, but so far, no major interventions have a significant impact on the rates overall. This gives you a sense of the data for conservative data for different illnesses. And yet there is a perception, and these are just some thought leaders in the field who've been funded in ways that are controversial. But thought leaders in the field in the 1980s and 1990s went around telling people that psychiatry with our magic pills like Prozac could prevent suicide and could cure people in this way. So now the public expectation is we'll be able to do this. And when it doesn't happen, when there are tragic outcomes, people view it as a failure. So you can compare this to oncology. Like antidepressants, chemotherapy helps some of the people some of the time. In oncology, when a patient dies, the hospital, the doctors, the surviving family blame the disease. Nobody blames the patient. Nobody blames the doctor. In psychiatry, far too often we blame the provider, even though we know that at present suicide is the course of the illness for some patients and that suicide is highly unpredictable. And in fact, it's become dogma. This is the former mental health commissioner in my state. Suicide represents a worst case failure in mental health care. We must work to make it a never event in our programs and our system of care. Now replace the word never with cancer, and you understand how absurd that sounds. Obviously, we would like no one to ever die of cancer, but we'd never phrase it in those terms. I suggest this is not the way to reduce suicide. So patients come to the ER, and what is their experience like? And this, again, is courtesy of Dr. Poor. It's generally not positive. So you can look at the percentage of people who, for example, felt safe after leaving an ER, versus 5% versus 23% who don't. But the most important number on the most important slide in this entire talk is what percentage of people, according to this survey, felt comfortable returning to an ER in the future. And the answer is 7% felt comfortable and 45% didn't feel comfortable. That means the patients who come into the ER suicidal, who we are treating, if we treat them and they didn't need to be there, or we admit them and they didn't need to be admitted, are less likely to come back when they actually need care. So that's why I suggest that we might be doing it wrong. So a bit of background on liability. Liability for outpatient suicide is a very new phenomenon. I've actually written about this. So between 1927 and 1962, there were only 15 cases for suicide liability in the entire country to reach the appellate courts. And virtually all of them were either for inpatient care or elopement for inpatient institutions. The first case of outpatient liability for misdiagnosis of suicide risk in New York State occurs in 1982. I believe the first case in the entire country is in 1978 in California. Lawsuits against psychotherapists doubled between 85 and 87. 1987, a quarter were for suicide. Now, a majority, both of suits and successful suits against psychiatrists are for suicide is too narrow for suicide or self-harm. And yet we adopt still a one-size-fits-all approach. So what I suggest is there are some patients who do need acute interventions. There are also patients, for example, the borderline personality disorder patient who is under stress, who is chronically suicidal, who probably should not be brought to an emergency room and certainly should not be admitted under those circumstances. And yet, the APA's consensus guidelines for BPD still say that they may be judged as serious risk and hospitalized. Doctors, children fear doctors, adults fear doctors' bills, and doctors fear lawyers. So we've gone from a profession aimed at making people well into one of keeping them from doing harm. So we all know there's a desperate shortage of psychiatrists out there. I always like to tell people, and this is true, there are more psychiatrists in the clinic I work in than in all of Wyoming. And as Alan Schatzberg said a decade ago, psychiatrists don't need to look for business. Psychiatrists, in essence, can cherry pick their patients. As a result of cherry picking their patients, who do they choose? I imagine not people on this call necessarily, because you are vested in suicide, but in my experience in New York City, there is a large percentage of providers who will not treat a patient who has a history of serious suicide attempt or who has recently thought about suicide. So in other words, the patients who most need care are least likely to get care. In fact, I wrote that in the New York Post about a decade ago, and I can tell you that the healthcare system I work at was not happy when I spoke about that publicly. But the reality is true, that if you call up private practitioners in New York City and try to get an appointment, and you tell them that you had a serious suicide attempt or you're recently contemplating suicide, most of them will tell you to go elsewhere. In fact, many providers will send these patients to the ER when they become high risk and then refuse to take them back. So Coleman and Schaller report that using standard generally accepted predictors, physicians will misidentify or misdiagnose 25 potential suicides for every one person who actually kills themselves. So we think 25 more people are going to than actually do. As a result, outpatient providers and ER psychiatrists err on the side of caution. And this was my training too. Better 99% of patients who would not have committed suicide are hospitalized and overprotected than one patient kills themselves. And from a liability perspective, this makes sense because you only see the patient in front of you. You see the visible victim of your failure to commit or failure to hospitalize. What you don't see are the invisible victims, all the people who were hospitalized by either you or others unnecessarily or over-inclusively, who next time, when they really are high risk and really do need care, don't come back to their psychiatric provider. So it's a paradox because physicians who are acting in good faith, liability shouldn't decrease suicide risk. All it will do is lead to caution and excess of the appropriate clinical judgment because we shouldn't be admitting people we think are at high risk anyway. So if we actually think you're dangerous to yourself or others, we should admit you because it's the right thing to do clinically and ethically, not because of fear of liability. Liability for suicide, which is the current law, actually leads to over-inclusive behavior. And yet it's not what families would want. Tort compensation for liability rewards families after the fact and makes them whole. My guess is if you asked families a priori, you have two choices. One choice is if your relative did end their lives, you could sue a particular provider and recover. Or two, you wouldn't be able to do that, but we believe that overall suicide rates would go down because people would feel more comfortable coming back to the ER if need be, and your relative's risk of suicide would be lower. Almost all rational actors would make the second choice. And that's why it's a paradox. So my radical suggestion to you is that eliminating outpatient suicide liability actually might lead to better outcomes, and it might be the best way to tackle the purported suicide epidemic, and yet it's something that we're afraid to talk about. And that was my 45 minutes on the nose, and I will stop and take some questions. Let me stop sharing my screen.
So much. I will take over from here. And we can see my screen. Okay, let's see what we got. Thank you so much. Everyone, we are open to questions now if you'd like to submit them.
The great thing about being on Zoom is if you want to throw things, they bounce back at you.
I am not seeing anything, but we will stay open. Are there any frequent questions you usually get, Dr. Appel?
Yeah, so I think the question I get most often is, well, this is all really good in theory, but I'm a clinician in the field. What do I do with this information? And the problem is, to be candid, it's very hard for you to do anything with it in a concrete way on your own, because when you see the patient and you still face liability, institutional pressures, you don't want to take that risk. And I don't blame you and don't fault you. So I think much more action has to be taken at the institutional level. These are the kind of questions that should be on the APA agenda, that should be on the agenda of various professional organizations. There is lots of pushback in a wide area of psychiatric forms of liability. But we have sort of swallowed whole cloth the belief that suicide liability should be the norm, helps patients, removes poor providers and the like. I just don't think that's true. And I think we would be best served if that was one of the areas that our professional organizations tackled. And hopefully some of you who have more power than I do will try to get them to do that.
Mhm. We do have a question on whether you have any comments on children's suicidal thoughts and actions.
Sure. So children are much harder, because on the one hand, sort of like the person who breaks up with their prom date and wants to end their own lives. In some way, suicide by children raises all sorts of red flags for us as not a, even expressing it, not a normal course of existence. And parents are going to feel much more strongly about wanting their children protected. So my short answer is that the same principles about liability definitely apply. I imagine that lots of children are being overcommitted, over-hospitalized when they don't need to be. But our diagnostic tools, at least, and I'm not a child psychiatrist, but my sense is our diagnostic tools may not be as effective in figuring out who they're going to be and who they're not going to be. And as a human being, because I do sometimes see children in the ER, the thought in the back of my mind that I may have to tell this parent at some point that their child ended their life or be involved in that kind of case does weigh on me differently from an adult. So it's a really good question for which there is unfortunately no good answer.
Uh, Thank you. We also have a question on, are there different considerations for psychologists and therapists as opposed to psychiatrists?
In general, no, in the sense that both organizations, lobbying bodies, have really not taken up suicide liability, and that suicide liability has now become widely accepted, not just by psychiatrists, but by therapists. I know it is true that that psychiatrists are more often likely to get sued for suicide completion and have a greater risk. But what actually has happened is, at least in my experience, when therapists have suicidal patients, they quickly shift them to a higher level of care. And even though their goal is not to abandon the patient, in practice, the patient ends up feeling abandoned and then is reluctant to start care with another therapist again. So that's something to really think about. If you're a therapist with a high risk patient and you shift that patient to a high level of care and they are stabilized, and then you say they're a high risk patient and you won't take them back, what that does to the patient. Now, I'm not blaming anybody for that. Our liability system is set up a process where that's the rational thing for you to do. It's just a rational thing to do that doesn't serve patient care.
Yeah, thank you. Do you have some practical ideas on how to adjust our field or society?
Oh, absolutely. I think it can occur both at an institutional level and at a professional level. At the most obvious institutional level, there should be no culture of blame for negative outcomes. And I've seen this in various institutions. For example, when a residence patient either attempts to commit suicide or commits suicide, we have a root cause analysis, and the focus is what the provider did wrong. That should never be the case. Because overwhelmingly the provider didn't do something wrong. Obviously, there were more safeguards you could have taken. But if you took those safeguards and applied them to every patient, you probably would have less effective patient care, more patients who didn't trust you, and it would not be the ideal outcome. So the best thing to do is to be supportive of our staff, our ancillary staff, to recognize that it's a traumatic event for them too if there's a negative outcome, and view them as part of a team rather than in an adversarial relationship. At a more policy-oriented way, and I've done this before, and I urge you all to do it, lobbying your professional organizations to get them to put suicide liability on their agenda. If we want to, or if we're concerned about suicide and people being cavalier about it in the profession, and my personal belief is there are very few, if any, providers out there who are cavalier about it. We go into this profession in part to help people, and we don't want them to harm themselves. But if you're concerned about that, the state licensing board is the ideal mechanism for dealing with it, not a tort system that is somewhat haphazard. It's interesting because other fields, obstetrics, orthopedics, have done a very good job at pushing back in various ways against liability for outcomes that seem inevitable or are very common. And psychiatry has really not taken up that mantle.
Great, thank you. We are going to take one or two final questions. We did get a question on liability and lawsuits. So in your experience, if a clinician carefully documents their rationale for not hospitalizing a patient for suicidal risk due to the factors you have mentioned, but instead uses safety plans and connecting the client with their family or friends' support, is this typically sufficient to avoid liability or lawsuit?
It can certainly help. I mean, the two challenges are there's the issue of being sued and the issue of winning a lawsuit. And most of the techniques we use in the hospital setting actually don't keep you from getting sued. They keep you from losing a lawsuit. But as anybody who's been sued, including myself, knows, simply the process of litigation, depositions, even just the stress of knowing that it's out there is highly burdensome. And unfortunately, these tools are less effective at keeping people out there who simply want their day in court or to express their frustration from suing. The standard I generally use, I teach the residents this in all matters of liability, is the thing to ask yourself: if I went before a jury of my peers and I explained to them what I did, or I read the chart and the chart explained, and I should explain in the chart the rationale for what I did, and their response would be, that seems what a reasonable, compassionate doctor would do, then, barring extraordinarily underlying facts, you're probably going to be okay. And if I read through the chart and I say, you know, that doesn't seem like what a reasonable doctor would do, even if it meets every rule and guideline and standard of care, it still seems highly problematic, and then you're going to be in trouble. You're not healthcare professionals. They use a gestalt common sense. Does that seem like a reasonable thing to do standard?
I think that makes sense. All right, we'll take a final question. It's a little bit more broad, and it wants to know if you have any thoughts on the internet's impact on suicide.
So absolutely, it's hard to know whether the internet is increasing people's likelihood of committing suicide, or whether the internet is simply letting people who already were going to commit suicide at some point connect and either have it occur more quickly, or like the Werther effect, commit suicide in similar ways to others where there's a contagion effect. I think the internet is best thought of rather than as an inducer, as a symptom. The fact that such a large percentage of people get their mental health information from the internet, and in essence live their lives socially in the internet, is what creates is what reflects the hazard that we're not connected with other people. So I will add, and this is a very unpopular view, I am very concerned about all of these internet-based therapy type programs, in the sense that if your world is already isolated and we're giving you another tool that in essence reflects that isolation to help with your mental illness, that might not be ideal. I understand we're in a pandemic and there are limits, but I hope after the pandemic is over, we spend the emphasis both on getting people back into the office with us, so they see another flesh and blood human being. They have to leave their apartment or leave their home. And also that we once again try to build social structures, clubhouses, groups, things that people can do with each other, because I really think we underestimate the impact of isolation, both on negative mental health outcomes and suicide.
Yeah, well, thank you so much. If you guys, for the questions we did not get to, if you want to email me, my email's on the screen, sthecart@adaa.org. We can send them over to you, Dr. Appel.
Absolutely.
Great. I would now like to thank everyone for joining us, and thank you, Dr. Appel, and for all of our participants at today's training. We would like to invite everyone here to register for our 2021 Anxiety and Depression Conference on March 18th through 19th. Admission includes access to all live sessions, live Q&As, posters, and exhibits over the conference dates. There are some great opportunities to network with your community, extended access to more than 100 recorded presentations for 2 months after the conference, and the opportunity to earn more than an estimated 100 CE or CME eligible sessions. I think it's going to be a great program. And if you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer, including year-long access to continuing education webinars such as this one. Members get free CEs, access to special interest groups, including online peer consultation groups, promotion of your practice, and ADAA's Find a Therapist database, and much, much more. To learn more, visit our website, or you can email me at sicard@adaa.org for more questions. And with that, I would like to finally thank you all for joining us, Dr. Appel. It was wonderful having you here.
Thank you so much.
Yeah, and everyone have a wonderful day.